Hi there. I'm really excited to introduce to you guys Angela James, who is a principal physiotherapist and founder of Sydney Pelvic Clinic. She is a pioneer in the treatment of men and women's health pelvic issues by applying a holistic and integrative approach to her treatments. And that treatment includes pelvic organ prolapse. Hi, Angela. Welcome.
Hi, Amy. Thank you very much.
We're very excited to have you today. And before we get started, I just want to remind our listeners and our viewers that content in this series is intended for general information and it shouldn't replace medical advice, diagnosis, or treatment from a trusted healthcare provider. We're going to discuss today conservative management for pelvic organ prolapse and how we can get women back doing the things they thought they'd be doing prior to having the diagnosis. So
yeah, absolutely.
Can we get started and talk about, I guess, what brought you into this field?
Into pelvic health?
Yes, absolutely.
Yeah. Well, I get asked this question a lot, actually. A lot of my patients ask me, I would get asked that question at least daily.
Right.
I certainly thought when I first started physio that it was all going to be about sports for me. I was a sportswoman. I played national level hockey. I was kind of sports mad growing up. And so I certainly went to uni thinking that that would be me. But I just came to realise that sports injuries was not really my calling, and the pelvis wasn't really taught that well at uni, and it was a sort of a gaping hole in my intuitive sense around the body. And when I did my first pelvic course, I think I was second year out of uni, it just light completely opened up. And I've never looked back. So I've sort of been in pelvic health for the last 12, maybe 13 years. And I just absolutely love it. I'm still fascinated, and I'm a continual learner, and I can't get enough. So I just love that it means such it means such a lot to people when it's going well, and when it's going badly, it has such a big impact on people's lives. So I guess I feel pretty useful when I help women or men fix the problem, whatever that problem is, and just get back into life, whether it's, sport or sexual function or just having normal bladder and bowel habits. I love the feeling of watching that transition and feeling like I played a part in it. So it's a wonderful area to work in.
Brilliant.
Yeah.
Brilliant. So can I ask, when we talk about conservative management, what does that mean?
Yeah.
So if someone gets a diagnosis of pelvic organ prolapse, can you talk maybe more about that diagnosis and what that can mean for those of us that don't really know all the different types of prolapse? Maybe we should touch upon that too.
Yeah, sure.
Yeah.
Yep.
Yeah.
Well, conservative management, I don't love the word conservative because it almost sounds inferior to surgical. It sort of almost sounds like surgical is the gold standard, and, if you don't want to have surgical, maybe you could try this inferior option of conservative. But conservative just means non-surgical. And in the case of pelvic organ prolapse, the evidence base behind conservative management is really strong, unless there's a really strong indication that the woman should be having surgery, then conservative management should be offered as first-line management. So under that umbrella, it really is pelvic floor muscle training, lifestyle habits around bladder and bowel, and exercise advice, which is a big topic, and I'd love to be able to talk a bit about that at some point. And then a fitting of a vaginal organ pessary. So all of that kind of sits under conservative management, and certainly should be offered as first-line management for women.
Okay. It's interesting that you say that. So if a woman is displaying signs of prolapse quite quickly, for example, I guess our listeners or viewers are postpartum women or women that have had children. But if it's quite early on and they're perhaps seeing an obstetrician or, gynecologist, do you think that is offered as the first, like conservative management is offered as that first line of defense? Or do you think women are advised to maybe have surgery? I think there's
Well,
enough awareness in those two sort of
yeah,
healthcare providers
spheres.
coming together, kind of thing.
Yeah, I understand your question, and I would like to think so, because that's certainly what should be offered in those early days, particularly when things have just changed so rapidly and will change again with the right, treatment and time away from delivering the baby. But I guess it really does depend on the bias and perspective of the healthcare provider that the patient is seeing. But the evidence-based advice at that early stage should be really conservative management. Surgical management really shouldn't be on the cards in those early days, and really shouldn't even be discussed at that point, other than like if all else failed in the long distant future, maybe, but it shouldn't be the first line option at that point. So I'd really like to think that doctors that have those really important conversations with patients that will set expectations and educate the woman about what she needs to be doing to look after the pelvic organ prolapse should be around referring to a really good pelvic or women's health physio to help her through that. I'd hate to think the surgical discussion would happen at that point, because it wouldn't be setting the woman on the right course at that point.
Okay, so I guess if a woman has presented and perhaps her specialist at that time has said, you can just have surgery, and hasn't given her other options, can you kind of, aside from the fact that she's postpartum and the body goes through a massive amount of changes in that early postpartum period, is that the main reason why surgery shouldn't be considered? Can you sort of elaborate why women should explore those other options?
Well, I guess it would come back to what I've said, is that conservative management is first line management. So that's really what the woman should be exploring at that point. And chances are that she will do really well with that and get the outcome that she's looking for, which is basically not to be bothered by a sense of vaginal heaviness, dropping, dragging, something not sitting right, not held back into her exercise choices, and able to empty her bladder and bowel appropriately. That's really the outcome of what you want when you manage prolapse, and she can get there with conservative management more than likely. So plus, you'd imagine at those early days, we've both been there with little kids, that's having surgery is the last kind of thing that you want to be thinking about. And also it's not really where effective management lies at that point, because of how much change has happened and will happen in the first sort of 6 to 12 months postpartum. So you wouldn't be making any sorts of calls about surgery at that point. It's way too early, unless something major has happened. But in I don't know percentage, but 95+% of cases at that point, a diagnosis of prolapse should be conservatively managed.
Okay. So can you tell us a little bit more then, sort of go into the conservative management, what happens, for example?
What happens? So with the symptoms, so if a woman has got a vaginal or pelvic organ prolapse, the most common symptom is a feeling of vaginal heaviness, bulging, dragging, something not sitting right. Rarely it's associated with pain. It's more something just isn't sitting right. Sometimes people can feel it, and it can be it can vary through the day. So often worse if there's a long period of standing or a lot of carrying, settling the baby in a standing position. It can be more prominent after you've emptied your bowels. And sometimes it can be associated with frequent voiding or incomplete emptying of the bladder, hard to start, urination, also incomplete emptying of the bowel. So they're kind of the mix of symptoms that would indicate that there might be a pelvic organ prolapse.
Right.
So really, if that's the mix of symptoms, then I'd suggest that you'd present to your pelvic physio or women's health physio. You certainly don't need a referral to come and see us. So, but if you, you can also go through your GP and hopefully they refer. But so that would be the way of getting into seeing the right health professional. And then really it's about a subjective assessment. So the physio will sit you down and ask you a whole bunch of questions that you might not have thought about. So we ask things about bladder and bowel, sexual function, symptoms of the prolapse. So sometimes people don't link those things. They can sometimes feel like lots of separate things, but often just the myriad of symptoms under that umbrella. And then the women's health or pelvic physio, we say pelvic physio because we see men as well, so I'll use that term, goes about assessing the woman. So that for a pelvic organ prolapse, most likely will involve a vaginal assessment if that's appropriate at the time and the woman consents to that, where we look at asking the woman to bear down so you can see, you know, what compartment is moving, whether it's bladder, whether it's uterus and the cervix, so the top part, or whether it's the posterior wall, so the rectum, or even a little higher it can be. And then we look at sort of pelvic floor function to see how well that is supporting the area or not. We look at whether the bladder's emptying properly, those sorts of things. And then depending on what we find, we can make a diagnosis, which is really important to help the woman validate her feelings. So what is that thing that I'm feeling? Well, that's actually your, you know, bladder sitting a little closer to the entrance, and that's why you're bothered, and making it all make sense, making sure the woman understands.
Validating those feelings, because I certainly hear it time and time again, and I'm sure a lot of our viewers and listeners will feel the same, is they need their feelings validated, and they're often told that it's normal, but is it normal? Is it normal?
It's common, but not normal. So that's it's about 1 in 2 women after a vaginal delivery will have some level of pelvic organ prolapse. So that's really common, but not all women are bothered by it. And it normally, when it sits a little lower in the vagina, it will bother a woman. So if it sits sort of around the introitus or the entrance, the woman will normally feel it. Sometimes they don't, and some women feel it a little higher. So everyone's sort of sensitivity is different. But it is really important to chase it. So I think something that I've noticed in clinical practice is if the woman reports the symptom and isn't assessed properly. So say if someone assesses her and they don't actually get her to bear down appropriately, then the prolapse can be completely missed. And sometimes it's really important to assess the woman in standing, to actually to find where the prolapse is and to see where it occurs. So you've sort of got to chase it a little bit sometimes. So, but then being able to then find the deficit and link it to the woman's symptoms is a really important thing. So it all makes sense, because once something makes sense in our body, we can get on and manage it and then not worry about it. And that's a big thing. Good management will help the woman sort of file the symptoms back and then be able to get on with the rest of the things that she needs to be doing, rather than being kind of constantly bothered and worried about feelings in a pelvis that don't quite make sense.
Do you find though, I mean, for your postpartum women, or women that are in that early stages of diagnosis, there is a lot of worry, and how do we sort of articulate that? I guess your life isn't over, your life as you imagined isn't over, because I think a lot of women, and certainly in my experience in supporting women that are impacted by physical birth injuries, is there's a lot of doom and gloom out there. You go on Google and it tells you that you shouldn't do this and you shouldn't do that, and you do become and from personal experience, and completely overwhelmed by your body's limitations. How do you manage that? How do women manage that sort of emotional fallout? Any advice around that?
Yeah, look, I totally get that. And I find that a real shame that women are held back by things that occur in this time period. And that's one of our major focuses, is getting women back into things that they love doing, because that's you know, that's important on so many levels. And I think that's when women really move forward. So I think one of the biggest things is getting the right advice and the right help, and that allows the symptoms to make sense and to be managed to the point where they're no longer affecting her everyday function, and she has confidence that things are going to be okay. So I think having the right support person is crucial, that gives her evidence-based advice and not fear-based advice. I think that's really important. And one of the big things that I'd like to get across is, you know, the idea of what you can and you can't do, that's hugely controversial. And you know, it's great at the moment because it's really being looked at with science, because we've got all these sort of ideals about what exercise is right, what exercises are safe, what's pelvic floor safe and what's not. And that's being put through the ringer at the moment to really make sure that if we are giving women advice to not do something, that we've got credible evidence to make that call, because the impact of having the woman not exercising and doing the things that she loves is huge.
Absolutely.
So if the woman goes into fear and goes, oh my gosh, I can't do A, B, and C, which are the things that I love for my, you know, mental and physical health, that's a really big compromise. And to ask the woman to compromise those sorts of things, you have to be really sure that that is a very important thing for her to do, you know, to avoid worsening whatever it is that she's got. So that I'd really like that discussion to be out there, because the notion of pelvic floor exercises is not evidence-based yet. And there's quite a few studies coming out showing that for the large majority of exercises in a low impact environment like Pilates and yoga, you know, cycling, even running is starting to be really questioned. And some studies comparing about pelvic floor safe versions versus just normal versions. There's not a huge amount of difference for those types of low impact exercises.
That's
so high impact has a it is. And I think it's really freeing women up to be able to go back into things that they thought might not be good, and not be held back by so much cueing and you know, focus on the right breath technique and everything has to be perfect so my organ doesn't move. Like, that's not it. That's not supported by evidence.
It also takes away all the pleasure of exercise. I mean, the beauty of exercise is that not having to think and just be focused on the task at hand. So to completely take away that pleasure, because you're like, okay, I'm gonna, you know, I mean, again, from personal experience, I just stopped yoga, which was such a massive thing in my life. And because I couldn't go to a class and put my legs too wide apart, and all of these things made it really difficult to get to a yoga class. And now, you know, I'm allowing it back in, and I'm not noticing any difference, but I'm definitely noticing a difference in that mindset. But you talk about finding a trusted, you know, source of advice, your healthcare provider. And that's where we kind of, what can we say to women when they are seeking advice, or they're going to see a specialist? Obviously here in Australia, you can see a women's health, a pelvic health physiotherapist. You can get a rebate back through your health fund. How do we know that we're seeing the right person?
Oh, that's a good question. It's a hard one. It's a hard one. Because it has changed a lot in the last, you know, 5 to 10 years. There's a lot more pelvic physios out there working with postpartum women. And there's varying levels of training and experience, as with any profession. So possibly looking at level of experience and level of education is a good start. So there's a lot of very experienced pelvic health physios out there, and there's a lot of very well trained, you know, postgraduate qualifications, for example, the Masters of Women's Health postgraduate down in Melbourne. There's the University of South Australia Pelvic Organ Prolapse course. So Yeah, that's probably the things that I would be looking at is the level of experience and level of training, and don't be afraid of getting a second opinion,
Yeah. Okay.
particularly if you feel like you haven't got the outcome. So if you've gone and you've been really confident with the advice and you're back into the things that you love doing, that's what really it's about. Where if you like, I still feel my symptoms, or I haven't found the perfect pessary and I'm still not doing my yoga, and I'm still not doing my Pilates, and I'm really scared about running and I can't see how I'll ever do that again.
Mm.
Um, I would seek a second opinion, because the goal of your treatment or your management should be allowing you to get back into the stuff that you love. And if that hasn't happened, I'd be looking at who could help you do that, because that's the bigger picture of your management.
I love
Yeah.
that. I think the second opinion with any healthcare provider is probably
Yeah.
quite important. If there's any sort of niggling doubt in your mind, get a second opinion,
Yeah, there's no harm.
yeah, and I think
Mm.
also maybe word of mouth counts for a lot as
Yeah.
well. That's generally how I find my practitioners is all through word of
Yes.
mouth, and then
Yeah, it's fairly powerful.
once I've heard the name, then I'll do my own research. But I find that that's
Yeah.
useful as well. But you touched upon
Yes.
pessaries. We are going to do
Mm.
another video about pessaries. But talk to
Mhm.
me a little bit about that, because I remember when I was told about my prolapse, actually before I had my prolapse, but I knew I'd sustained injuries, I was told that
Mm.
I should just live the life I want and I can have surgery when I finish having children. And then I saw a brilliant
Mm.
pelvic health physiotherapist, and she said, we'll get you fitted with a pessary. And I was told by the same previous healthcare provider that pessaries are just for old women that don't have sex. And
Mm.
I remember thinking, oh gosh, I shouldn't have a pessary. A pessary for
Mm.
me personally has given me back
Mm.
so much.
Mm.
Can we talk a little bit about that and what
Mm.
they do, what they are? As I said, we're going to have another a longer video on this,
Yes.
but let's talk about that,
Yeah.
because it's another form of conservative
Yeah.
management, right?
Yeah. No, yep, I love pessaries and more than happy to talk about them.
Yeah.
So I think one of the things that you said is that they have been seen as an older woman's thing.
Mm.
And all of the research projects and the evidence based out there use a cohort that are in that category. So, 50, 60, 70 years of age. But, I guess the thing as pelvic physios, we've probably brought the pessaries into the patients that we see, which is the postpartum women.
Mm.
And I guess it's so perfect for physios because it's a support device that allows you to work with compromised tissues to get back into the things that you love doing. So
Yeah.
I describe it to my women like a knee guard. So if you had sort of a dodgy ACL ligament from, I don't know, skiing or something, and, you're pretty good most of the time, but you can't play touch.
Mm.
So because of the instability in the knee, so put your knee guard on, and you can, because the knee guard gives you that external support where you don't have the internal support, and then you can get on and play touch. So that's great.
Mm.
And pessaries are really similar. So it's a vaginal support device that kind of allows the organ to sit and stabilize in a better position so that you can load the body without loading the organs. So it's such a fabulous device, so simple.
Mm.
But it's really pelvic physios that have brought it back into postpartum women and allowed women to sort of self-manage it, put it in, take it out, just like they do with moon cups or tampons.
Yeah.
These sorts of things weren't really happening sort of 5-10 years ago. And I think physios have done a really awesome job in sort of bringing something out of the closet and allowing and like fitting the right pessary to the right woman and then allowing the woman to get back to stuff, because that's really what it's about. There's all sorts of different shapes and sizes. It's such a long conversation, and it really has to be fitted well. But if you get the perfect pessary, you shouldn't feel anything. It's like a tampon. You don't feel the pessary, you don't feel your pelvic organ prolapse. and you can do stuff,
Yeah.
and that's what it allows. And you can learn to self-manage, which is awesome. So I think that's really good. It's, you know, putting the power in your hands, so you're getting better and better at self-managing, which is wonderful. Yeah.
Yeah. Okay. That's brilliant. So I guess, like, we've talked about pessaries, we've talked about importance of second opinions, and that you can get back to doing activities that you love. Is there anything else that you would like to add that you think it's really important? I mean, I would say I think all postpartum mothers should see a women's health physiotherapist.
Absolutely.
Or pelvic health physiotherapist. I've got to get used to saying that. Before commencing exercise. Or, you know, treat yourselves, go for an MOT.
Yes.
You know.
Yes.
So,
look, I think it's a really important thing, and I just sort of feel if men had babies, would have this amazing sort of process around managing it well.
I can't help but feel exactly the same.
There'd be a protocol, and there'd be funding of some sort. And I think it's such a physical thing to be pregnant and to deliver a baby, and it's so important for women to be exercising and returning to stuff that they love. And to support that, you have to rehabilitate the vehicle where it all happens, which is the body. So I think that a 6-week check is such a fabulous idea, because it allows the woman to understand what's happened to her body and identify risk before she re-engages in physical activity. You know, to get those questions answered. You know, can she do a pelvic floor contraction? Does she know what it means to train her pelvic floor muscles? Because they need training after just being pregnant, and particularly if you've had a vaginal delivery. What other muscle?
I've heard something about a percentage, and it might have been out of the US, but it was something like 70% of women doing pelvic floor exercises are doing it incorrectly. Like, that's a massive percentage, isn't it? Like,
that's right. Yes.
There's not really anywhere where you can get that information definitively, and you can, although you can, there is more so out there, but it's much better to be assessed. As kind of confronting it can be to have someone at your bits, making sure you're activating correctly. I think it is really important to make sure we're doing it correctly, because the cues that are commonly used are incorrect, you know. So and that's so important. So that's right. So there's a research study that says that if given verbal instructions alone, so Amy, do your pelvic floors, 70% will get it wrong. You know, like, so does the muscles engage? And sometimes they don't. So do they engage the same on the left and the right? And do they engage adequately? And what does it mean to train your pelvic floor? Like, do you walk around just bicep curling all day long to train your bicep curl? You don't. So you need to be given the right script for you. It needs to be very individualized. So it has to come from an assessment. It needs to be progressive to be able to get the outcome. And, you know, I guess one of the things that the poor pelvic floor struggles with is it can't be seen. So you don't get that, you know, motivation by toning the pelvic floor because it looks nice, or, you know, out of sight, out of mind. But you know, it controls bladder, it controls bowel, it controls sexual function. It provides stability through the back and the pelvis. So I wish that women would understand more how important that muscle is. And even though the poor pelvic floor exercises can feel boring, how integral they are to the long-term health of the woman, and how much they can protect against things like, you know, surgical and surgical complications in the future. And, you know, I guess right at the end of the woman's health span is that it's the second most common reason for women to be admitted to nursing homes is incontinence. So we know there's so much more we could do on a preventative health level, but, you know, it doesn't get the attention that it deserves. So I think that's probably a really big message, is to have that 6-week check. You know what you've got, know what to do, know what your plan is to return to your things that you love doing. And I think that's really important. Like, it's not just the check, it's also, okay, what's my plan so I can get back to my trail running, or I can get back to my, you know, high intensity class, or whatever it is that the woman wants to be doing, so that she can see the steps that she needs to take to get like life
back
Yeah.
to to re-engage.
Yeah, I
Yeah.
think you go to a physio, you want them to say to you, what do you want to do? Let's help you get there, rather than
Yes.
you can't do this, you can't do that.
Yeah.
And going back on the pelvic floor, that it can be overtrained as well. I think because there is a little, I mean, tell me if I'm wrong, but I feel like there's a little bit more awareness out there about pelvic floor
Yeah.
health. And you see the sort of well-meaning, sort of well-known personal trainers or fitness professionals out there that talk about, do your pelvic floor exercises. And I can just imagine lots of women go away thinking, okay, pelvic floor exercise, and then there can be the fallout from that, right? Because you can also have dysfunction or prolapse with a really good,
Yes.
the really strong,
Yes.
pelvic floor, right?
Yes,
Yeah.
you can, and I guess it comes down to the assessment. So
Yeah.
you can't assume that the pelvic floor is doing what the pelvic floor should be doing, and you just can't get at it from verbal instructions alone. So yeah, get it checked. Know what yours is doing. Know what it's not doing. Know how to get it into optimal form, and get on and do the exercises, and don't leave it to the personal trainer, because they can't see it, they can't feel it, so it's got to be better than that. We've got to do better than that.
Yeah, we need Medicare to start subsidizing the
Yes.
6-week check. But I think that's brilliant. I mean, thank you so much for your time. We are going to do, as I said, I've mentioned numerous times, we are going to do another film on pessaries. And I'm also going to be talking to a fabulous fitness professional that's going to talk about why a 6-week check from a GP or your obstetrician may not be adequate. And
they're looking for different things.
And why we're going to encourage perhaps women that want to get back into training to see a pelvic health physio. So thank you.
Perfect.
So much.
Oh, my pleasure, Amy. Thank you.
We've given some useful information.
Yes, I hope that was helpful.
Thanks, Angela.
Okay, thank you. Bye.
Bye-bye. Bye.